Hi, everyone. um, Utah, really cool state. We're from the East Coast, so we're just so excited and think this is a beautiful part of the world. So, my name is Elke Chebetz. I am a family nurse practitioner, and I work for Georgetown University. And I also work closely with Afton here in clinic. Our patient we have about 5 clinics across central Virginia, and we have about 3,000 patient encounters for people who are on hormone therapy or starting it. And so we're from Virginia.
Hi, everybody. My name's Afton. I use they, them pronouns, and I'm a nurse practitioner at the Virginia League for Planned Parenthood, as well as do a lot of contracted trainings with Virginia Rural Health Association and others to expand more folks in primary care doing more gender affirming care. So thank you.
Yeah, go ahead. Go ahead.
Sorry, I'm used to also seeing this like from this angle, so apologize for that. So our slide deck is heavy, and the reason that is to make sure that this is a short amount of time. We wanted to leave you all with a lot of resources. So just to be aware, we'll move quickly, but not always touch on everything because some of the content is there for you afterwards. Before we get into some of the specifics with health, I think it's important to kind of frame the center of what it means to live and operate as a trans and non-binary person and queer person in our country, and to recognize the historical bias and discrimination that's existed in our community. And often when we think about healthcare, we like to focus on health disparities and these unchanging, unmoving statistics that affect our community. And I always like to make sure that we all center and agree that when we think about these disparities that the community faces, that it is not the individual or the person being trans, queer, or non-binary that is leading to these discriminations, that it is the systemic discrimination and interpersonal conflicts that we see exist. And that obviously when we think about our identities and we layer on more identities that are oppressed in our society, whether that be you're Black and brown, Indigenous, speak a primary language that's not English, are facing poverty, or live in a state that is perpetuating systemic violence and criminalization of your body, that those are obviously going to impact things like your mental health, your overall well-being, and we need to work and advocate in more global and macro ways to challenge that in addition to the direct care we do. So I like to highlight that too to center gender dysphoria, because we use this term a lot in medical practice, whether it is using it to give a diagnosis or using it more so for coding relating to the care we provide, and understanding that within that same discrimination and political context that the DSM has also been used in historically negative ways when we think about gay and queer and trans folks. And we know that that existed back in the 70s when we think about especially gay and bisexual men, but anybody who identified as same-sex loving. And then we continue to see newer iterations attack and focus on trans people and centering our identities as a mental illness. And we still operate under that same lens while this code is getting moved out of the DSM and moving into the ICD. I like to highlight and frame that it can be pathologizing to trans people to still utilize these terms and diagnoses. And often the way that I like to frame it with the individuals I'm working with is that when we think about gender dysphoria, we can think about using that distress piece that's inside of that coding to think about the distress that we experience operating in as individuals and existing as trans people with the external environment and stressors. So sometimes it's not the individual person's identity that's in itself that is dysphoric, but trying to operate and navigate in a world that really wasn't meant or built or created for you. Oh, yeah, sorry. Oh, no, I don't think this works. Okay, cool. All right. Sorry. Give me a second. Sorry. I got, there we go. Okay, cool. All right. Okay. And I know that this has been reflected already in other presentations this morning, and I'm sure will continue to be present throughout the conference. But when we think about our practices, especially if we are a practice that doesn't provide gender affirming care, we often can forget the importance of collecting SOGI data. SOGI stands for sexual orientation and gender identity, and thinking of what it means to integrate into our EMR systems or whatever databases you're using for your clients to make sure that we are collecting this data, but also using it in a meaningful way. So I tell people it's great if your system or your intake asks somebody's pronouns, but if it's not being used in a meaningful way throughout those encounters and throughout their continued care with you, then it often can be even more stressful to that person because we're giving the impression that this is a safe and affirming space. But if we're not using that data in a meaningful way, it can sometimes be a double trauma. And this can also impact things when we think about like insurances and claims and what that means to that was spoken in the laboratory piece earlier. So when we're thinking about providing care for this population, I think it's important to think about how we collect data, what kind of questions we ask, and that means that we often have to challenge the norms that we've been taught and ingrained in how we collect healthcare information about bodies. So I always like to highlight that, when we're thinking about providing care to people, we want to avoid inappropriate curiosity. So when we're thinking about what questions to ask, asking these questions of, is this pertinent to the care I'm providing? Is it going to be helpful? Or is this something that I've just been thinking about and now I have my first trans person in front of me and I can get that information? And that's not the avenue we want to go down. So these are just some helpful questions for you to have when you move on in practice. If you're unsure of how to start collecting, like what organs does somebody have present? How do I ask questions about somebody's history with transition? These are just some good starting places and examples of how to navigate that. Similarly, this is just a good table that I reference if you don't already have a good organ inventory, anatomic inventory, surgical history in your data systems. These are some good templates to start to operate inside of. So the other last kind of, I say, housekeeping thing before we get into the nitty gritty is thinking about paperwork. And the other things that we often don't think of as medical providers, we're often focused on the direct clinical care, but beyond that, what are our responsibilities and advocacy that we need to provide. With a lot of the gender affirming care, especially hormone therapies and surgeries, there's a lot of work that has to be done with prior authorizations and medications and sometimes challenging appropriatenesses of screenings. For example, like mammography for a trans woman who's been on estrogen is now in her 50s, but her insurances are listed as male. And so sometimes there's lots of things that we have to do that we aren't always considering when we send out folks. Thinking too about billing and coding. Like I said, we have that gender dysphoria code, but others might use a more generic code related to endocrine disorders to help protect some of that fear and stigma that exists inside of places. Before the ACA, you being trans was a pre-existing condition and you could be denied insurance, and that stigma and fear still carries over, especially with a lot of older patients that I work with. Thinking about what space you operate in terms of surgery referrals. Can you provide gender affirming, surgery letters and referrals and recommendations, and what legal documentation that we can assist our patients with? So even if we're not the ones providing hormone care or providing that surgical intervention, often we can be the person that helps sign those affirming documents so somebody can legally change their gender marker on certain forms or their name. And there's a lot of space that we can operate inside of that's beyond just prescribing a medication. So when I think about the word transition, I like to define it first really quick before we talk about hormones, because we all have a different preconception of what that means. And I say it depends. Everybody is individual and there is no one textbook definition of what it means to transition, but I like to frame it under 3 large categories that kind of help frame when somebody comes to us and says, I'm transitioning, we can dig and explore that further. So I like to think of social, legal, and medical. And so when we think about social transition, those are the things we can do every day, the way that I'm presenting today and look and appear, changing my name, using pronouns, things like that. Legal transition can be those official legal steps that we do to do some of those things too. So changing your birth certificate, changing your name, and then medical transition, I think, is the one that we're the most comfortable and familiar with. And when we hear that word, and that's thinking of things like hormones and thinking of surgeries and other sort of like prosthetics and things that folks can use to help affirm their gender.
Go ahead. Yeah. So this kind of care has, gender affirming care has made me a better provider in general for everybody. And the reason is that I've learned to individualize care even more. And it's not always with all my patients that I'll sit there and, but really the first question that comes flying out of my mouth when I do a lot of telehealth as well as see people in person is like, are you surrounded by loving, affirming people? For me, mental health wise and just in general, that's probably the most important question to ask somebody while they're in transition is, do you feel safe at work? Do you have a bathroom to go to? Are you holding your urine? Things like that. So really just breaking it down, it not only is helpful to get information, but it also lets the patient know right away, like, you understand my issues. And so that's really, really helpful to sort of open up with those affirming questions and things. And so you can see here that when we're educating our front desk staff or educating other people, it's not just the care, the hormones itself. It's not hard. It's easier than diabetes but it's just so complex with the social navigation part of it. Are you got that? Did you go forward? Okay. Oh, okay. Am I on the pink slide? Okay, perfect. So you can see that, we often have people who are in the middle of, they're coming from different states, they've lost their housing, they've been kicked out, they're broken up with their partner, or are coming out of jail. You can see here that there's some violence and trauma to talk through. And so we have a listserv in Virginia that's called the Transgender Healthcare Alliance of Central Virginia. And that's where Afton and I often work with each other is through this care, because you have to know where to send people to. It's right. It's not like just like, oh, I'm really sorry. It's like, where do you send people to? So knowing where your resources are is really, really important. And I highly recommend, when we gave this talk in WPATH in Montreal this past fall, we had people running up to us to find out about this listserv. Just, it's the most easy thing. What you want to do is just get all the allies and the thing will grow. The listserv will grow, but you'll also get a list of people who are mental health or social workers, or we often throughout the day, I'll get an email saying, do you know anybody in Fredericksburg who takes Anthem healthcare insurance, who will see a 16-year-old? Things like that. So we'll come across our desk. So everybody will jump in right away and say, yeah, they can see this person. So it's really, really helpful to sort of know that. Medical interventions do you want to include, again, masculizing hormone therapy, feminizing hormone therapy, and as well as blockers. And you can see here that surgical interventions, top surgery, mastectomy, and to sort of talk about with the patients about where they are in their goals. Are they considering gender marker changes? Have they considered name changes? Is there anything that they're looking, that they're wanting that is being offered in their state or their insurance is covering? And so knowing where they are, often I ask people about, like, are you wearing a binder right now? And then they'll start talking like, no, I'm not wearing it, or I wear it part-time. And that's where I get into, are you having any rashes? Because it's getting really hot out. A lot of times tinea will form underneath those. So I'll say you could take some antifungal spray and use that, or remember to take it off, or give yourself a breather, or just little things like that to kind of, again, help them and make sure that it's not too tight so that they can also breathe. So, do you want to take over that? Yeah.
And kind of reflecting on what Elke was talking about, I think it's important too to have a general concept of some of those, non-official medical devices and assisted devices that people use to affirm their gender, because they do impact the care that we're providing. Even if we're not providing hormone therapy, just some of those good whole body primary care aspects of care. So being familiar with binding and, fortunately, these days, I don't think many people are still using ACE bandages and tape as I used to see many years ago. Thankfully, there are binders now and most people have access, but maybe they don't. So, we've partnered with like local youth organizations and things like that to have like binder donations and other things. So thinking creatively about some of those community networks you can get involved with. So if you do have a patient needing those services, where can you send them? Being familiar with tucking, so for folks who are assigned male at birth, tucking is the use of things like medical tapes or using other devices like gaffs or control briefs to help, again, kind of minimize the appearance of their genitalia that they were born with. And there are some health things that can happen too with that when we think about restricting and tucking, similar to binding. And then silicone injections, I throw out there to say that I don't see as many patients these days now that are new into using silicone injections and thinking now medical grade silicone, like what you would get from Home Depot, for example. But I do manage a lot of patients that historically have used silicone and now are, living with the health consequences later on related to granulomas and other, I tell people when you inject free silicone into your body, you can't control where it goes. And so they're now needing surgery to kind of remove and take care of some of those complications. And thinking of things like packing, padding, those other things like vocal therapy and different things that beyond, like I say, like what we can do from pharmacokinetics, and knowing the importance of these devices when somebody walks into your room. So if you are performing an exam that's more invasive, thinking of what devices can somebody retain? Do I need to know what devices somebody has right now that might impact like what I'm doing? So for example, if somebody is coming in and is having genital discomfort and they're tucking and have tape on and I don't know that, when I go to do the exam, I'm not going to be able to do that with that medical tape and gaff in place. But having a conversation before the patient gets undressed and describing that. And then importantly, as soon as I'm done with that part of the procedure or exam, having them be able to use those devices again before I move on to the next part of my exam so that it is as comfortable as it can be and more affirming in those spaces. So just some examples of binding, like I said, tucking, kind of an anatomy diagram of what's happening if folks are unfamiliar with it. And like I said, you definitely can notice sometimes people will come in with testicular pain or infection or things related to this. And often it's just around good, safe hygiene and technique. And we're not taught these things in healthcare and in med school and nursing school. So we have to do some of our own learning to be able to provide those healthy wellness tips for folks. And luckily there's tons of great resources online created by our community. So we don't have to go too far.
Sure. Talking about. So basically starting about estrogen and anti-androgens. And again, we have a lot of speakers talking about this subject, but just giving the lowdown. I always open up with patients to say, tell me what you know about hormones, because then you get an idea about what they know, what they want to know, where they're getting their information from. A lot of times we have some blog sites that people will be on and things like that to sort of get their information. So also I will give them the email to, or the web address to, like, for instance, University of California, San Francisco, to say, this isn't voodoo. What I'm doing, you can see what we're doing along the way. And this is for providers and for patients alike. And you can even talk about primary care. And with primary care, because this talk is about primary care, one of the first things that we want to find out is, do they have a primary care provider? And most of the time, I would say about 80% don't, or they haven't seen them for a long time. And so getting them connected to care, and I'll often use the example, for instance, is like skincare. I want to check to see your skin and make sure you don't have a melanoma growing, especially in young people. They think they're invisible and they don't really need wellness exams, but that's when those sort of instances happens. And so I give a lot of examples. I use a lot of analogies to sort of make people understand how important it is that we also see them in person if they're being seen on telehealth. Anything else you wanted to add to that? Okay. So again, this is from University of California, San Francisco guidelines. And so what we do when we start with feminizing GAT is we start low and slow, particularly in the first 3 months. We have the patient sign a hormone consent form. Sometimes we use our informed consent model. When they come in, they've got a really good idea about like what's going to come. A lot of times they've done their homework. They already know more than we do. And so we'll just start them on, 1 milligram twice a day, usually a 2 milligram dosaging for the first 3 months. And then and we see them every 3 months, and we do labs on them. We'll do pre-labs. And then we'll talk a little bit. So a lot of times they'll come back and they'll want to know about injections, or very rarely do they want to know about topicals. But with the elder folks we have patients that come in and starting hormone therapy. They've been thinking about it their whole entire lives. They're starting it when they're 60, 70, or even I've had an 80-year-old start on hormone therapy. And those sorts of people will have a lot of comorbidities. And so safely starting them on things, considering what their medical background is, we tend to use patches or even creams on people just so that they have, and this is just going by the data that we have now. Anything you want to add? Okay, and then we use blockers. We use spironolactone, and again, starting low, 50 milligrams twice a day, and then sometimes we'll go up once we get some data back, which is usually like what are the testosterone levels at, as well as getting a basic metabolic panel to understand what their electrolytes are. We're sort of on the fence. We just sat in a conference about like, do you take it sublingually or do you take it orally? And we're sort of, again, it's just a conversation to have with people, the way they take their estrogen. These medications are not controlled substances, so they can, a lot of times people are moving and coming and they're going to school or they're moving here, moving there. So we just remind them that they can move with their hormones so that we don't get a lot of calls back about like, I've moved and I need you to change my pharmacy to this, because you can imagine we have a lot of questions coming back. So we try to field those as well. For the people that might have some hair loss or androgenic hair loss, or that we want to mitigate that, we also will add finasteride. And so it's not a strong androgen blocker, but we also tell patients that it's one of those medications that is not covered by any insurance. And so what we like to do is give the 5 milligram and have them either cut it into quarters, or sometimes we'll have people who actually take the 5 every single day. It's one of those also medications that you don't want to have anybody who is cis female in birthing range even touch the medication. So again, it's just a conversation to have to remind people, like, you have to remember that you should know what you're taking and what are sort of the side effects, or, how are you handling this medication? And then again, this is we start at our clinic, we do start people around 12 months or 14 months or 15 months, just depending on have they reached their maximum estradiol levels for testosterone suppression. If they haven't, we'll add progesterone. And what we do is, I at least preface it to say, we don't know how long you will be on progesterone due to safety reasons, or if it's even going to give you any yield. But what we have heard anecdotally, and Afton, I think you're going to, is that I tend to say, fills in the breast tissue. It gives a little bit more of a curve and also anecdotally, it makes people sleep a little bit better at night. So we have them take micronized progesterone at night, and they usually really, really happy with the effects they have. But again, after about 2 or 3 or 4 years, we're sort of like, we're not sure of the safety indications. So it's not one of those medications they'll be on until we get more data. Yeah. You want to add? No. Okay, we got a lot to cover, so we feel like we're on all the good. This is a really, the Rainbow Health from Ontario are really great also websites to sort of peruse and go back to. You can use our slides as well. But sort of this expected time course of feminizing hormones. Most people are very clear this is going to take a while and they shouldn't expect things overnight. But again, people sometimes are shocked about the acne that they might be forming from testosterone levels. And so again, being a primary care provider, you'll want to talk about ways to mitigate that. Sometimes I've had patients where I've been like, let's just ratchet it back a little bit on the testosterone and see if that might help. And it did for them. They started losing their hair right away and they were getting upset about that. So we just lower the testosterone level. So again, you can see how it's individualized, but a lot of times I'll also provide them with acne medication. And if their acne is very bad, sometimes I'll refer them to dermatology to get some Accutane. A lot of times I've had dermatologists call me and go, they need to be on 2 forms of birth control, but that can be very traumatizing to somebody who's not having sex with anybody that could get pregnant from. So I've had to actually have a conversation with dermatologists to say, no, it's okay. They're on progesterone or whatever it is, or they're not having sex with somebody. It's perfectly fine. And as long as they talk to somebody who does this care a lot, they feel pretty comfortable about that. Starting Accutane. Some of the testosterone psychological the things to consider are just, again, changes of hair. Um, it will, depending on people's goals, if they're coming back and they're wanting more facial hair or maybe some more body hair, we'll also um, suggest that maybe they want to use something like Rogaine or minoxidil for the topical areas for their face or their arms or their legs. And so that's also a kind of a little, as well as testosterone and just managing expectations. It also has a lot to do with their genetics and stuff. And so um, the one thing that I will say that I often have to sort of emphasize is, when was your last pap smear? Sometimes they never even have had one. And so getting them into an affirming care clinic is really important so that we can use the right size speculum. It's not traumatizing them, and sort of having the conversation that is something that you might do every 5 years. It just depends on, at least want to do at least one screening for you and kind of engage you in the care and with somebody they trust. Anything you want to add to that? Okay. We got, okay. Masculizing hormones, again, just testosterone tends to be injections. This is again from University of California, San Francisco guidelines. Afton in a former time would also have to deal with the pre-authorizations for people wanting either creams or gels. They sometimes will need pre-authorizations if you want people to even switch on. So you'll have people who are like, I'm out of my tea. What am I supposed to do? I'm waiting for pre-authorization. So these are the hiccups in reality for healthcare providers, and us and you all know pre-authorizations are the bane of our existence. So just a kind of a heads up on testosterone gels, when you want to prescribe them, sometimes they'll be kicked back from the insurance companies, and they're pretty expensive compared to injectables. Again, it's not one of those medications that you can just change states with. We have patients who will do maybe a semester abroad or 9 months abroad in another country. And so what we do is we have a team that helps to get them letters for them to move with their testosterone, and to inform the country that they're living in that this is legal, and they're being transparent about what they're taking with them. So as long as they're working ahead, we can work with them on, moving around or things like that. Telehealth has also been an issue with, we can't prescribe for people in other states if we don't have the licensures in that state. So anything you want to add to that? Okay, we're moving along. These again, expected time course of testosterone on, I'll ask them, has your menses stopped? A lot of times, they're really happy because it usually stops pretty quickly. When it comes to voice, you might have heard, we have voice trainers in our region that do free voice training for people. With testosterone, it'll often be one of the first things that people start to notice is their voice will drop. When it comes to feminizing hormones, people will have to work on their pitch and tone with a voice therapist. And so we have people that will give, again, free classes in groups or things like that, which is really great. People, again, knowing your resources and knowing your speech pathologists and speech and language people is really important, because they might be interested in getting trained if they haven't already been. And these are some of the guidelines when we're talking about resources from WPATH, from UCSF. And then you want to take it over? Okay.
And so thinking about when we are seeing patients in a primary care setting, and thinking about, some of these surgeries that we've explained that folks might explore. So this slide just really lists out at least the majority, if not 99% of the surgical options that exist in our country for trans and non-binary folks, to say that we're not going to obviously spend time to go through each one of these, but to be aware that there are many different surgical interventions that can be acquired that affect different parts of the body. And so that when we are getting that health history, it is important that we are aware that we're not just focusing on, for example, like top surgery, removing the breast tissue, or chest augmentation with like breast implants, or bottom surgeries, colloquially known with like vaginoplasties and phalloplasties. So how do these impact things like sexually transmitted infections that we might be seeing in a primary care setting. So when we think about folks who are AMAB, we can think about, that there's, if they still have their neovagina, that they have the same healthcare risk when it comes to STIs. So thinking about what surgeries are present, what organs are present. But if, they've had a full hysterectomy, pregnancy is no longer a risk. But if they haven't, testosterone does not make you infertile. And so pregnancy risk should be something that we're considering and counseling on as necessary. And then, and sorry, I misspoke when I said AMAB, I meant to say AFAB. And then for AMAB folks, thinking about the neovagina that's created with a vaginoplasty, they do carry the same risk for STIs, but often they can have symptoms that can mimic STIs. And we sometimes go down the wrong rabbit hole because a lot of times with the technique with vaginoplasty, they're using external tissue and those hair follicles can regrow. And so sometimes you can see things like folliculitis inside the vaginal canal and other symptoms that might make us start to go down an STI path when it actually is more related to the anatomy that is present and thinking about what tissues are present in that neovagina.
When you're talking to AFAB, AMAB patients, just remember when you're talking about surgeries, somebody might want to have an orchiectomy, but if they're considering a neovagina in the future, they're using that tissue, so they might want to hold off. So it's good to have that conversation as well.
And then for AFAB folks, so non-binary folks, trans men, I like to highlight with bottom surgery that there are many different techniques and options when it comes to the surgery, and that sometimes just getting the information that they've had a phalloplasty, for example, or a metoidioplasty isn't really enough for us to know what health risks exist, because some of those procedures do remove the vagina. You do have a vaginectomy. Others require urethral lengthening, and sometimes people don't do that, and they retain their own urethra and natal anatomy. And so thinking about really knowing what specific things have happened with that surgery can be really helpful if somebody's coming in, for example, with urinary symptoms or other concerns for us to properly work up and address. I say we don't know what we don't know. And so sometimes that's why, and knowing that when is the right time to ask those kinds of questions. So when we think about primary care, I think it's important to think about, what considerations, even if we're not the ones prescribing hormones, what falls under our space as that primary care provider, even if we're just monitoring patients and not prescribing. So thinking about what we know in terms of these medications with estrogens and anti-androgens and the risk involved. We've talked a little bit already about hair removal and also, things like finasteride to help decrease hair loss. The typical lab monitoring that we're doing when people are on things like spironolactone, being a diuretic and impairing possible effects related to different kidney functions, to thinking of things like metabolic panels. Importance of, we see a lot of patients, because we do provide primary care as well, who have hypertension in the setting of on estrogen therapies and anti-androgen therapies. And so being careful and monitoring if we do have them on like an ACE and ARB to monitor their hypertension, if we're adding that spiro, what that means for their potassium, and maybe needing to monitor them more closely, or if you're the primary care person not providing that care, coordinating with their hormone provider, hey, I'm adding this into their regimen for their hypertension, and so that somebody is aware to monitor some of those extra risks. Tobacco, I'm not going to go into ad nauseum. I think we understand the tobacco risk associated, especially with estrogen. And then, just thinking again, like I said, of those possible surgeries and what that might mean for different symptom profiles that people present with. When we think about folks that are on testosterone-based therapies, I think everybody's familiar, and especially anybody who attended the last couple of workshops here already, about erythrocytosis and the effects on hematocrit and hemoglobin. And also, I think importantly, as was highlighted in that first presentation, not allowing the hormones to send you down a train that we're ignoring something that's being masked by those hormones. So for example, there's a lot of anemia that we unpack in our primary care offices for patients on testosterone, because that testosterone is elevating that hematocrit. And if somebody hasn't had access to a healthcare provider in many years, it's gone undetected. And then if we're only looking at that hematocrit, we're missing, the potential risks there for anemia and other concerns. Birth control, important, of course, if folks are needing access to it, and also sometimes utilizing it as a means to for period suppression and other opportunities when testosterone isn't something on the table for somebody to be able to take. You often might see folks come in with abnormal uterine bleeding that isn't associated with hormone therapy and sometimes can be. And so I think it's always important when we think about the symptom and profile picture that somebody's presenting with us, it can be really easy and tempting to blame the hormones, just like we tend to blame trans people's transness as a reason for a lot of their symptoms and profiles. And so trying to really unpack and, kind of stop that historical pattern and to say, it might be hormone related, but if I'm narrowly focused on hormones alone, what else could I be missing? Like what other conditions or other profiles might also mimic these symptoms so that I'm not missing a potential malignancy or other risks that we know that can associate with like abnormal uterine bleeding, for example. Vaginal atrophy is a big one that we see sometimes too with the testosterone. And so you might have patients come in with pelvic pain or cramping, especially during and post sex. And so thinking about ways that we can monitor or help refer out to trans-affirming gyne and reproductive health if that's not a space for us to be. We talked about binders already and some of the skin concerns that can happen. Also, you can impact breathing difficulties if binding's not done properly. So sometimes we can be good educators, especially with our adolescents, on like good healthy binding techniques, especially if they're active and playing sports and all that kind of good stuff.
A lot of times people think, oh, I'm on testosterone. I just have to deal with being uncomfortable down in my bottom area. And so I like to be proactive and say, if you start getting a little bit uncomfortable down in the area, your body doesn't know that you just switched hormones. So it's almost like we threw you into menopause. So just so you know, we can give you this a tiny little bit of estrogen topically, and that will help a lot. And so, because otherwise people are just going to be like, oh, I just have to deal with this because I'm on hormones. So it's just real important to stay ahead of it.
Since I know we're coming close to time, we're going to wrap up with some really quick things about good screening and preventive care, primary care bread and butter. Importantly, when we think about screening and preventative care, we need to think about not only what somebody's affirmed gender is, but also what that historical health picture has been in terms of hormones and surgical use, because we can easily end up missing important education tools and recommendations if we're focused only on either somebody's affirmed gender or only on their hormone profile and missing things like surgical histories too. So what we know so far is that, when it comes to breast cancer, it's important that we're having these conversations with trans women and non-binary folks who are assigned male at birth. Typically right now, the current recommendations are to, you want to start considering breast screening like you would for cis women after they've been on hormones for at least 3 to 5 years and become age appropriate. And then also considering the family history, just like we would for cis women as well, in terms of like BRCA risk and things like that. For trans guys and non-binary folks, if they still have breast tissue present, so they haven't had top surgery, follow the same guidelines you would for any cis woman as well that still has that tissue present. And then for cervical cancer, we've talked over a lot about pap smears and the uncomfortableness of that. And this is where I also highlight, as Elke said, providing and prescribing hormone therapy is not complicated medicine. We know that trans people face a lot of barriers and shame and stigma and fear going into doctor's offices and accessing care. If you can be the best, almost one-stop shop place, that is fantastic. So as a primary care provider, if you can provide that pap smear, that person already trusts and respects you, the same as providing hormones, trying to eliminate the amount of different people somebody has to go to and then disclose their identity and potentially face discrimination and trauma is also a really good trauma-informed approach. We know when it comes to prostate cancer, hormones aren't affecting the prostate, so same guidelines, and there's no surgery to remove it. And then we do know that we do see a potential small risk of diabetes increase in folks on estrogen, and so important, just like any population, when they get age appropriate, but maybe falling a little closer. We also, I tell people with our older patients, especially on estrogens, thinking about that bone health and bone risk. So thinking about the similar things that you would do and monitor for cis women as they start to age and get into their 60s and 70s and 80s. You want to not neglect your trans women in that space as well.
Yeah,
and I think
the labs, we had a wonderful presentation earlier. Just remember that the lab, you can go through these slides and just, a lot of times labs will freak primary care providers out. They're not sure about like what to do. And it's just, I know that we're up on time, but you can take a look at these slides and just know that there's only a couple of lab considerations that are very, very specific to natal gender. And so otherwise you're going by either when they start their hormones or if they're in the middle of their hormones, just go by. If they're been on masculinizing hormones for a bit, go with that lab value.
And I think that that's a good place for us to wrap up because that was the end of our clinical pieces of things. So thank you all. I'm sorry that we ran a little bit over. I know it's going into your break time, but we appreciate it.
Yeah. Sorry about like whipping through this. These resources here, these books here by DM Maynard are fantastic for families and parents, as well as teachers and partners. And so those ones I'm always telling patients about.
Thank you both very much. So we do have a little bit of time for questions. If there are any, audience, please raise your hand and we will get the mic to you if you need that. If not, it is our break right before lunch. So thank you very much.